All right, welcome everybody. We're delighted to have you here today for our symposium on Mycoplasma genitalium. My name is Damon Getman. I'm Scientific Director for the Medical and Scientific Affairs Group at Hologic. I'm based in San Diego. We're really glad to have you here. We're grateful also to IDSOG for giving us this opportunity to continue a long-standing narrative on research on M. genitalium that began at Hologic about almost 2 decades ago in San Diego. We had seen data begin to emerge on this new organism, Mycoplasma genitalium, that seemed to be associated with non-gonococcal urethritis in men. And the data was showing good associations there and also some associations of upper genital tract infections in women. That was of interest to us, so we decided to begin making research assays to the organism using the same chemistry that we use for the Aptamacamo-2 assay. This is using transcription-mediated amplification to directly amplify ribosomal RNA. And those assays were then subsequently used in a number of research studies over the following 10 years to really help define the natural history and epidemiology of M. genitalium in various patient populations and begin to get a sense of how it associates with disease states in people. By 2015, the evidence base had increased to the point where the STD treatment guidelines included a section on M. genitalium for the first time, but because of the lack of clinically validated tests, FDA-cleared tests, there couldn't be any recommendations about who should be tested or how they should be tested. So finally, in 2019, we filed a de novo application with the FDA and got clearance. This is the first IVD-NAT cleared by FDA, which has greatly accelerated the testing of M. genitalium in various patient populations. The 2021 treatment guidelines now include a much more comprehensive section on M. genitalium, who should be tested and how it should be treated. Dr. Weisenfeld did a very nice job yesterday reviewing that. But now these tests are being rapidly adopted by laboratories, and we thought it would be appropriate to begin education sessions for providers to understand where this infection is, what patient populations, who should be tested, who should not be tested, and how to treat these infections when patients show up in your office. So to help us in this endeavor, we're fortunate to have 2 experts in the field of STI research and clinical practice and understanding natural history, epidemiology, and clinical management of M. gen infection. Of course, they are familiar to all of us here at IDSOG, Bobby Vanderpool and Will Geisler, both from the University of Alabama at Birmingham. Bobby is professor of medicine and public health at UAB. Her research is focused on understanding the biological and behavioral factors that affect susceptibility to and prevention of sexually transmitted infections, and she's also active in projects designed to improve access to sexual health for underserved and minority populations. She's director of the STD Diagnostics Laboratory at UAB, also directs the STD Clinical Research Organization there. She's past president of American Sexually Transmitted Disease Association and the current president of the International Society for STD Research. So if you're going to the STI HIV conference in Chicago next year and you want to score extra drink tickets for the opening reception, Bobby is the person you need to talk to. Our other distinguished panelist, Will Geisler, of course. Will is professor of medicine and epidemiology at UAB. He has been a leading voice on defining the optimal treatment strategies for M. gen infection, especially difficult to treat antibiotic resistance cases, and he will bring some case studies with him today, which I think will be very interesting. When he's not doing research, Will is assistant dean for the Physician Scientist Development Program. He also directs the Physician Scientist Development Office there. He's director of the STD program, research director for the Mycoplasma Laboratory, and director of Infectious Diseases Laboratory. So I'm not sure what you don't direct at UAB, but given your schedules, we're delighted to have you both here. So Bobby, I think you are first.
Thanks for the somewhat lengthy and embarrassing introduction. I write these blurbs and people take them and use them, and then I'm like, oh, I've got to find a way to make that shorter. Just as a point of interest, I will say that I've been looking at Mycoplasma genitalium as a sexually transmitted infection for many, many years, and I think the first paper I published on it was in 2009, showing that it had a much higher rate in sexual partners of people with MGen, really strengthening that association with sexual transmission. So this has been an interest of mine for a long time, and I'm not going to speak for very long because this is mostly a session related to clinical management, but I wanted to sort of set the stage for Will and provide you with a little bit of background. I will start with a disclosure slide because obviously I think it's important to be transparent in this, and what you should take home from this slide is that I work with just about anybody and everybody. But the reason for that is if we don't work together, and I hope we learned this during COVID, if we don't do cross-sector work between academia, public health, and industry, we're all in a real mess when something comes out, and we're going to see it again with monkeypox. So I think hopefully we've learned that lesson, that these relationships are very important. So I'm going to start with some epidemiology, again, just to tell you why we're even bothering to talk about Mycoplasma genitalium. And a lot of people have contextualized this as the next chlamydia. And this Monday was my 40th anniversary of working in the field of chlamydia research, so that's where my interest first started in this field. And I was in that process and part of that group when we made chlamydia become a notifiable disease, and so bringing it from zero attention to a notifiable disease is a process I'm familiar with. And so as we think about Mycoplasma genitalium, which is now in that process, we can apply some of those same lessons. It's important to understand national prevalence, but it's really hard because we haven't had good tools, as Damon just mentioned, for many years. Now that we do have those tools, though, the first line on this slide is from the CDC, and it's looking at NHANES data and trying to estimate the national prevalence of disease. And I'll focus mostly on women since this is mostly a women's health type meeting. But we see about a 1.7% prevalence of mycoplasma in the US in a nationally representative sample. And for chlamydia, that rate is about 2.4, so they're similar. In a study that we did of a clinical trial that was not nationally representative but was situated in multiple sites around the country, in managing people who are seeking services for sexual health, the rates are higher. And so you can see in women in that group that about 5.3% of the women had Mycoplasma genitalium infections, whereas about 7.3% had chlamydia infections. Now, the last one that I have up here that is fairly representative is only from New Mexico, but that said, it's representative data for the entire population of New Mexico, and it's based on cervical cancer screening samples that were stored and that they were used across the whole state, and they weighted them for representativeness, and they came up with an estimate about 2.0% for Mycoplasma genitalium. They didn't provide a chlamydia estimate there. When you start talking about specialized populations, like those seeking sexual health services, I've shown here data from Melbourne in a clinic of men who have sex with men, because men are relevant, I'm just not focusing on them, but the data are there for you to look at. But they had about a 9.1% prevalence of disease among gay men in their clinic. And in the Netherlands, in an STD clinic that serves a large portion of the country, and because of National Health Services, is a little bit more representative than things we see in the US, they had a prevalence in women of 3.8%, but their chlamydia prevalence was 9.6. So what you see is that mycoplasma is similar to chlamydia in prevalence, certainly higher than gonorrhea, which I didn't show here, but we all know that gonorrhea rates are much lower. So when we think about Mycoplasma genitalium in women, why do we care? So hopefully we can share with you some things to convince you that it's an important disease. But up to 70% of these infections can be asymptomatic. Now again, we heard this with chlamydia, so it's very similar to the chlamydia story. Symptoms are more common when there are co-infections. So if you see somebody with symptoms, then you have to be even more concerned that mycoplasma might be there. And that's a key point for the screening recommendations that the CDC has issued. Now there are data, and I put a double asterisk here. This goes this is Maria Trent's data from Johns Hopkins University, showing that untreated infections often persist. But I'm going to caution you about these data because these were women that were seeking services for PID. And at that initial visit, they went back and retrospectively tested those samples and found out they had mycoplasma. It hadn't been treated. And when they called those women back in, those women still had mycoplasma very frequently, up to 50% of them. But so this is not in an asymptomatic population. This is in a population of symptomatic women. And as I just mentioned, women with pelvic inflammatory disease are often positive for Mycoplasma genitalium. So I use this slide all the time, thanks to Damon for collecting it, and I wish other people would provide us data from similar studies. But this was a large study throughout the U.S. that showed co-infection rates. So remember, these are not prevalence numbers now, but these are of those women that come in with symptoms and are diagnosed with a discharge-causing disease. This is the frequency that you will find these. I do want to remind you that trichomonas is still the most common of these. These women weren't assessed for vaginitis causes, so BV might have changed the picture of this pie chart. But even so, when we're looking at STIs, the next most common organism found in women with discharge was Mycoplasma genitalium. So it's quite common in women with symptoms. And chlamydia is only 9% compared to 25% with mycoplasma. So I just showed you prevalence data showing that maybe Mycoplasma is not as prevalent as chlamydia, but when we look in that symptomatic population, that story does shift, and that's what you're seeing here. But also what I've underlined is that Mycoplasma is very often seen with other organisms. So just because you get a chlamydia positive result doesn't mean Mycoplasma is not there. So when we test for only one or two organisms, we're often not getting the whole picture of what's going on in a woman. And so what are the sequelae and why do we care about whether or not we treat this? Well, in men who had urethritis, if they're not treated for mycoplasma, they often end up with persistent urethritis. And we'll talk more about these kind of cases, so I won't spend much time on that. Again, in the study from Maria Trent's group at Hopkins, we saw that in young women, these were 13 to 25-year-old women seeking care at an emergency department for pelvic inflammatory disease. 32% of those women tested positive for chlamydia, but 24% tested positive for mycoplasma. So it is there, and it is there in these women that are having complicated situations. We don't have excellent data about infertility, but again, like chlamydia, it's suspected that there is an association and there may be a causal relationship, but we need better data. And now that we have tools to collect that data, hopefully a few years down the road, we'll know more about what to do with this. And then, of course, pregnancy outcomes are a concern for those women that have mycoplasma that goes untreated. So here is Harold Weisenfeld, whom you heard yesterday, and Lisa Manhart, who's one of the leading experts in the country on M. genitalium epidemiology, did a meta-analysis, and you can see very clear relationships between cervicitis, pelvic inflammatory disease, preterm birth, spontaneous abortion. You can see that the infertility relationship is less clear. But again, I will say to you that just like when we did all this with chlamydia, these are associations. These do not show causality. So we really don't know exactly what's going on with these women. But we can't know those things until we detect the disease and really have a better understanding of how much is out there, when it's out there, and what happens to women who have it. So with that said, Damon mentioned the current testing guidelines, and I call them testing guidelines, but they're not really. They're in the screening, or they're in the treatment guidelines. This is from the version that was just published in 2021. But remember that we haven't had laboratory diagnostic guidelines from the CDC since 2014, and those were written in 2009. So those are woefully out of date. But so the only thing that people have to consider when they're thinking about how to test is the treatment guidelines. And in that, it says that screening asymptomatic patients is not recommended. And I will just tell you that when we're contextualizing this like chlamydia, many places in Australia and Europe are considering stopping screening for chlamydia among asymptomatic women. There's a huge debate about that right now, about whether or not there's really enough impact in that screening, given that rates have not gone down in response to screening, and balancing that with antimicrobial resistance concerns. So this is a common debate, and it's not restricted just to mycoplasma. But also, I should remind you that I speak lab speak, Will speaks clinician speak, and so when I say screening asymptomatic patients is not recommended, that's because the intended use for these tests is for symptomatic patients, and those are based on symptoms and sometimes clinical signs. But when they write the treatment guidelines, they focus on clinical signs. So while there's a difference between those two things, I'm going to be sloppy and just say asymptomatic, and hopefully you guys will follow along with me. So CDC recommends molecular diagnostics as the appropriate class of test or type of tool for patients with persistent or unresolved urethritis or cervicitis or PID. So they're not even just saying if you just come in and you have vaginal discharge, which would classify you as symptomatic, that still doesn't really even fall into this because they're only looking at people who have persistent infections. In Europe, it's slightly different. In Europe, they recommend treating men with signs or symptoms of urethritis, so they're not waiting for persistence. They're doing it from the get-go. And they're screening women with mucopurulent cervicitis or abnormal discharge and STI risk. So the recommendations here and abroad are very different, and we may be going in the way that Europe has gone, but we're not there yet. And I often joke about the flu-like symptoms of the STI world. You know, you always tell people, if you have flu-like symptoms, if you have HIV, the first thing you might notice is flu-like symptoms, or if you have Ebola, the first thing you might notice is flu-like symptoms. And so, to me, as an epidemiologist, those are the scariest terms on the face of the planet. But from genital STI terms, our flu-like symptoms are abnormal discharge, and dysuria. And remember that abnormal discharge is something that's a symptom a patient might report, but then if a clinician is doing an exam, you might see cervicitis. But in many settings, people are no longer doing a full pelvic exam, like in ER settings, for example. So you may not be able to distinguish between cervical discharge and vaginal discharge. And of course, in men, urethritis, dysuria, pelvic pain, burning and itching and tingling. And do these sound familiar? Well, they should, because these are the same things that we say, oh, if you have these, you might have chlamydia or gonorrhea or trichomonas or vaginitis, or even herpes, right? Because we know that herpes can cause some of these same conditions in people. So to have those symptoms is so generic and not super diagnostic, and you don't know how to treat people, which is what will go into. But if you're going to test, because people have these flu-like symptoms, the best sample type that you can use is a vaginal swab. Anybody that has a claim right now has claims for both patient-collected or clinician-collected swabs. And that's good because that allows women to be engaged in their own health care, and it also can improve clinic flow by letting samples be collected before the patient interacts with the care provider. Most of the assays that are available today in their intended use statement, which clinicians often don't see, but we laboratorians pay a lot of attention to, in their intended use statement, they strongly recommend vaginal swabs over endocervical swabs or urine from cis women. And that's because those sample types are just not as robust as vaginal swabs in terms of collecting a lot of material. So while the true organism load may be in the cervix, you get more sample with a vaginal swab. And then penile urine is the sample type that's preferred if you're testing cis men or transgender women. And it might not explicitly be stated that it's penile urine. It may just be called male urine. But trying to get away from gendered diagnostics, that's a thing that you know that you can do from penile urine. So what do we have available right now? I listed these in order of approval, and Hologic was the first to have an assay approved. And if you guys have any questions about assay specifics or details, I'll be happy to talk about that. But again, since that wasn't really the focus of the talk, I don't want to spend a ton of time on that. None of the currently approved assays from Hologic, Roche, or Abbott do detect macrolide resistance. So right now, all we can detect is just wild-type bugs. So it's presence of bug, yes or no. The Hologic Aptima Mycoplasma genitalium assay is a standalone assay, so you order it by itself, but it can be performed using the sample that you collected for CTGC and or TV testing and or vaginitis testing. The Roche Cobas assay has TV and Mycoplasma genitalium bundled together, which is an interesting choice because TV is usually in women and mycoplasma is usually in men, but regardless. But that can be run from the same specimen that's run with their CTGC assay. So again, just one specimen collection. And the Alinity M from Abbott recently got FDA approval, and that's the only true quadruplex assay, and it runs all 4 of them automatically. There are some research tools out there that I'll mention just because Will's going to be talking about macrolide resistance. And Cepheid has a generic a generic cartridge that has no primers and probes in it, and you can add the SpeedX reagents that detect both wild type and the macrolide resistance marker. Again, these are research use only, so you'll have to do your own validations in your local environment to see if you can use those for patient management. Hologic has a similar research use only tool that they're evaluating, and Hologic has a track record of taking tools like that, and if they showed to be clinically useful, moving them into the commercially available sphere, and so that's a hope for the future. And then Seegene has an assay that's available in the US that is a multiplex assay that includes macrolide resistance markers. But again, nothing that's cleared by the FDA. I do want to say a word about bundled testing because I just mentioned that most of these tests can be done from the same sample that you use for chlamydia, gonorrhea, trich, and that's great. But since you shouldn't be screening asymptomatic women for mycoplasma, that means that not every swab you collect will be tested for all 4. Some will only be tested for the 3. So it's really important that when you do your ordering, you make sure that the laboratory is made aware of exactly what you want, because the laboratory has no way to know any specific details about that patient's signs or symptoms. So we rely on clinicians to tell us only run CTG-CTV or run all 4. And most of the assays that are out there that can run multiple tests at once can allow you to mask the results, or you can save the specimen and retest the specimen. So you have options that if you have somebody who's not treated, work with your lab and see if you have to collect another specimen or if you can go back and retest that original specimen. It depends on how long they save things. So it would be nice for those tests that can run this automatically, even if you mask it for clinical use, if labs collect this data, so we could start building aggregate epidemiologic data throughout the country, and maybe eventually do research studies where we take those data and match them back with patient charts and understand the clinical utility of this testing. But so that's just kind of it in a nutshell where we stand. The disease is out there. The story is pretty similar to chlamydia's story. But we have a lot of gaps in our knowledge because we didn't have good tools. And our gaps are focused, I think, around the importance of asymptomatic infection. If asymptomatic infection is transmissible and their partner then ends up with persistent urethritis, then should we have treated that asymptomatic infection to avoid that downstream consequence? So I think we are doing a conservative process right now because of a lack of data. So I would strongly encourage anybody who has the opportunity just to collect more data. We don't really understand the importance of co-infection because almost all the studies that look at these things look at them in isolation. So somebody gets an MGent test, they run an MGent study, we see the MGent prevalence, but we don't see the chlamydia, gonorrhea, trich going on at the same time, which is why that study of Damon's gets used all the time because it's one of the few that actually did that. But we do have these better tools now. They're widely available. And so almost any platform that your lab has is going to have a tool that they can run on it. So we need population studies that are funded by federal organizations. And we really need to understand what's going on out there in terms of outcomes. So it's not just the cross-sectional prevalence data, but also follow-up data. And then we obviously need approved tests that are available to detect antimicrobial resistance markers with molecular tests. And so with that, I'm going to turn it over to Will.
Thank you, Bobby, for paving the way for my presentation. Thank you, Damon, for the introduction earlier. And thank Hologic for inviting me. So now I get the task. You've all eaten. You've had dessert. You've been sitting there a little while. I've got to keep you engaged, so I hope to do that. I'm going to talk a little bit about what the current treatment recommendations are, the resistance issues. Then I've got 3, I think, really interesting clinical cases that are at the second half of my talk. So I really hope you stay to hear these clinical cases. That's a teaser. And I do know so much more about M. genitalium treatment than I do like rickettsial infections and possums, I promise you, okay? So I'll do better with this presentation. So here my disclosures are relatively boring, I think, compared to Bobby's, but somebody comes to me every once in a while and asks to work with me, so here they are. It's mostly, honestly, NIH funding really supports most of what I do, particularly NIAID. So really, now that she's paved the way, talking about the epi and the diagnosis as it relates to treatment, I think there are kind of 3 major considerations. The first is availability of MGent test results. We know we have tests, but will you have test results? And when you have test results to guide you, will you have actually macrolide resistance testing as part of that? And that's very important in treatment. There is resistance, not only to macrolides, I'll talk more about that. And then, treatment strategies. This is not an easy organism to get rid of, and we used to use monotherapy with one antibiotic, and now we're talking about sequential or combo therapy approaches, so I will go through those. What I will say is there are multiple classes of antibiotics that in vitro there's activity against M. genitalium. But in vitro activity doesn't always necessarily translate to clinical efficacy in humans. So in the U.S., there are really three main classes of antibiotics that have both in vitro activity and some clinical efficacy data in humans. And those are your quinolones, particularly moxifloxacin, your macrolides, particularly azithromycin, and your tetracyclines, particularly doxycycline. But those other classes kind of listed there that aren't bolded are ones that either there's in vitro data but no published clinical data, or there is published clinical data, but we just can't get it in this country. It's in other countries. And so I'll kind of talk about some of those other ones very briefly when I get to the clinical cases. But it's mainly those three classes I mentioned. So of those three classes, the macrolides, mainly azithromycin, is the one that we've had some of the most clinical experience and published data on. And it used to work great for M. genitalium given as 1 gram single dose therapy. But then really within the last 10 years, we've seen considerate emergence of macrolide resistance. And because it's so hard to grow M. genitalium, there's only a few labs right now in the world that are growing it. Our lab at UAB is one of those labs, is that you basically have to, if you test for resistance, you have to find molecular markers, genetic markers basically. And so there is one established for macrolide resistance, and that's a mutation in the 23S rRNA gene, and I'll call that MRMs moving forward, that macrolide resistance mutation. What we do know is if you get infected with a strain that has one of these MRMs, most of the time you will fail azithromycin therapy, whether you use 1 gram, whether you extend it to a longer regimen. If it's resistant, you are likely going to fail treatment. And unfortunately, we've kind of done this to ourselves because we've been using azithromycin to treat basically almost every bacterial STI or STI syndrome. And it just so happens to be one of the #1 antibiotics prescribed in the U.S. for everything else. You have a cold, you get a Z-Pak. You might also have M. genitalium brewing there that you're developing resistance, right? And so, unfortunately, there are multiple factors that have been driving this. I think in the STI world, we're now moving more to stewardship to try to back off on this, but I think the damage is done as it relates to M. genitalium. How much damage has been done? Well, basically, if you look at the published studies, it's been a relatively small number still, but this map lays out the published study data, which is that overall 44 to 90% of the M. genitalium infections tested in these studies had MRMs. In particular, you look at MSM, the MSM population, that's where it's highest. In Seattle, 94% of MSM who had M. genitalium had MRMs. Even in Birmingham, Alabama, in our HIV-positive MSM, 74% had MRMs. So basically, if the patient has M. genitalium infection, probably 50% or more are going to have an MRM, and then most of those are going to fail treatment. So it's no longer like a reliable empiric treatment if you don't know whether a patient has an MRM. But we have no FDA-cleared test in this country to tell us if you have an MRM, so it makes it very challenging. The cure rates used to be pretty good, over 85% or so with azithromycin 1 gram, but if you look at studies that were basically conducted 2009 or later, the rates start to drop off, and it was about 67% cure rate, which is terrible. And in the most recent studies, it's less than 50%. So it really doesn't make a lot of sense to use azithromycin for M. genitalium if you don't know if it's sensitive or not. So quinolone resistance, quinolones are basically now our best drugs in the U.S. to treat M. genitalium, but there is resistance. But unlike macrolides, when you find these resistance mutations, it correlates very well with treatment failure. That's not the case with quinolones. You can find several different types of mutations in what they call the quinolone resistance determining region, particularly the PAR-C gene and the GYR-A gene. But just because you have these mutations with quinolones doesn't mean you're always going to fail therapy. But it turns out there's one very specific mutation called S83I. And you're going to hear probably more about this in subsequent publications because this is one that does correlate pretty well with treatment failure. And now individuals are developing probably tests to test for quinolone resistance using the markers for S83I. So I think that one is going to kind of make it eventually into diagnostic assays. And unfortunately, even now we're already seeing anywhere from 6 to 30% prevalence of these QRMs, they call them, in these patients. And usually if you have this quinolone resistance mutation, you also have the macrolide resistance mutation as well. So it's multi-drug resistant. So imagine if you have both macrolide resistance and quinolone resistance, what are you going to use to treat? Well, that leads us to this third class, the tetracyclines. So moxifloxacin cure rates used to be 100%, and most recent studies are like 60s to 80%, which is, again, from resistance. which leaves us with the tetracyclines. So doxycycline has never been a good antibiotic to treat M. genitalium. The cure rates in most publications have been less than 50%. But, it's been unclear, is that due to resistance or not? Those who have been able to grow the strains so far have not found resistant strains in people who have failed therapy. So there really did not seem to be a correlation. But even though it's not good at curing M. genitalium, it's pretty good at knocking down the bacterial load. And so one of the reasons you develop resistance to an antibiotic is because while you're on the treatment, you develop a mutation on the treatment. But if you can start treating an infection with a lower bacterial load, it's less likely to develop resistance. And so now doxycycline is a drug that's available to use in treatment strategies where you're not trying to cure it with a doxy, but you're trying to lower the bacterial load so other antibiotics work better. And one of the cases later, I'm going to tell you about that we have identified true M. genitalium that's tetracycline resistant. We've grown it, and we have the MICs, and we've sequenced it. So we know it's out there. And it makes me worried there's probably more out there that we don't know because other people can't grow it. And if we use doxy in the strategy to lower the load, we might just be eventually selecting for more resistance. That might not be good. So some investigators in Australia, they do great M. genitalium work there. I'll just start by saying that. Early on, and I'm trying to remember how far back, at least 2014, maybe 2015, they knew this was going to become an issue. And so in their routine clinical practice, they decided we're going to do something called resistance-guided sequential treatment. So what we're going to do basically is take a patient presenting with an inflammatory clinical syndrome like urethritis, cervicitis, etc. We're going to include M. genitalium testing at that very first visit when they come in, as well as other STI testing. We're going to go ahead and give them standard doxycycline for 7 days. And then basically, if they have persistent recurrent symptoms and they're MGent negative, we will treat the other STIs or address that. But if they're MGent positive, we're going to look to see if they have that macrolide resistance marker or not. If they don't have the macrolide resistance marker, then after those 7 days of doxy, we're going to give them azithromycin because they don't have a resistance marker. We're not going to give them 1 gram, though. This is a very slow-growing bacteria. We're going to give them 1 gram, and they give them 500 milligrams a day for 3 more days. And it's a very long-acting drug, so that's like giving 7 to 10 days of treatment when you do that. But if they do have the MRM, the macrolide resistance marker, after the doxy, we're going to give them 7 days of either citalfloxacin, which is a quinolone we don't have in the U.S., or moxifloxacin, one of those 2 quinolones for 7 days. So that was their approach. And then, of course, they're really good about writing up their data once they do these types of clinical practices. And so they put out 2 publications. In one of them, they had over 300 men and women. About 72% had MRMs. These were all MGent infected. About 72% had MRMs. The cure rate for those that were MRM negative was 95%. That's the ones that got the azithromycin as part of the regimen. The ones that were MRM positive was 92%. Those are the ones that got the quinolone as part of their regimen. And then they had the other study was a little bit over 200 men and women. 68% had the MRM strains, and very similar cure rates, 95% for MRM negative, 92% for MRM positive. And those are much better cure rates than they were seeing with monotherapy in their population. So this is a pretty big win. I mean, this is like the best treatment outcomes that we'd seen with this strategy. So everybody kind of got on board with the guidelines, basically, right? And so the CDC here in the U.S., UK, BASH, European, Australian, all recommend now sequential therapy. Just like their routine practice where you start with, for MRM negative doxy, and you follow that with extended azithromycin. And the guidelines differ based on how many days and some of the dosing, but it's summarized here. And then if you're MRM positive, you get doxy for 7 days, then moxy for 7 to 10 days, depending upon which guidelines you're talking about. So this is now, I guess you would say it's standard of care because this is what's recommended in the guidelines, and people follow guidelines for their standard of care. CDC specifically, recall from Bobby's presentation, there's no FDA-cleared MGen assay that gives you MRM results. Our lab actually at UAB can do that. We have a validated assay if you want to send it to us, but most people don't do that, right? So the CDC says if you don't have resistance testing available, skip azithromycin as part of sequential treatment, use moxifloxacin. But we all know there's some caveats to moxifloxacin. You might not want to give it to pregnant women. You might not want to give it to people who have tendonitis issues, arrhythmias, etc. And, it's also a very broad spectrum. It affects your microbiome, can lead to risk for C. diff, etc. But that's what the CDC basically says we should do because we don't have an MRM test. But if you do have access to MRM tests, then they want you to do the standard. If you're MRM negative, use azithromycin as part of your regimen. If you're MRM positive, use moxifloxacin. But now I want to present you, I'm going to shift and talk about 3 cases. And these 3 cases are all going to illustrate the challenges right now that we face. Again, the way that we're testing the U.S. for M. genitalium, the lack of resistance assays, the lack of, good drugs to treat it. And these are all cases I saw myself. I'm not making this stuff up. These are all patients I saw either in person or consulted on. So this is the real deal, all right? 32-year-old non-pregnant female, cis female, referred for persisting M. genitalium infection to me. She had a history of bacterial vaginosis and reported serious allergy to levofloxacin, which basically she developed severe tendinitis and then palpitations and came in, was hospitalized with an arrhythmia. So she did not want to take quinolones again. So she basically originally saw a GYN provider for vaginal discharge, odor. They did a pelvic exam, didn't see cervicitis, and I guess tested her wet mount, showed that she had BV, and they gave her clindamycin to treat BV, thinking this was kind of somebody that gets recurrent BV. They didn't give her metronidazole just because she had trouble tolerating it. They didn't do any STI testing at this first visit. They just treated for BV. So basically her vaginal symptoms didn't get better. She came back to the same provider. This time they didn't do a pelvic exam, but they collected a vaginal swab and tested in this multiplex assay that basically got STI and vaginitis pathogens. And she ended up being positive for M. genitalium, M. hominis, Ureaplasma parvum, and Ureaplasma urolyticum, which I don't have time to get into this, but I'll just say it drives me nuts that these ureaplasma tests are in these assays, okay? Because if you've ever been called by all these patients who are freaking out and they're going to die with their ureaplasma infections, you'll know what I'm talking about. And the lack of evidence that they actually do harm in this setting. But anyway, side point, she tests positive for all these things, and so her GYN provider gives her 7 days of doxycycline, refers her to a local infectious disease specialist who's like, hey, let's do sequential therapy. And so that ID provider added azithromycin after the doxy, though they gave the Z-Pack dosing, 500 day 1, 250 the next 4 days. And basically, her vaginal symptoms got better, but they never fully resolved. And she still had vaginal discharge. And this whole time, she had not been sexually active, and her male partner had been tested. He was negative, so presumably it was maybe the partner before this one that she had gotten it from. So there's 3 questions I'll ask you. If you feel like shouting out an answer, go for it. If you don't, for time's sake, I'll just give you some answers. The first question is, should STI testing have been done at the initial presentation with this female coming with new vaginal discharge? Yes, I see your head shaking. And the answer is yes. I mean, you're right, because, new vaginal discharge could, as Bobby said, be that flu-like symptom for the chlamydia, for the gonorrhea, and other pathogens. So yeah. So to me, they really missed the boat on that one. And then which STIs? What do you want to do? Chlamydia? Yeah. Gonorrhea? Yeah. M. genitalium? I see mostly no heads. I see a couple of yeses. So it depends. If you're following CDC guidelines, the answer is no. If you're doing what you think is right for your patient care, the answer is probably yes. Okay, but if you're following the guidelines, the answer is no. So then the second question I have for you is, should M-Gent testing have been done without a pelvic exam at that follow-up visit? They didn't do a pelvic exam, so should they have even done M-Gent testing if they didn't look for cervicitis? And the answer is, yeah, they should have done the M-Gent testing. So like Bobby already mentioned, is that now we have a world where we're moving away from doing speculum exams. They're uncomfortable, they take time, and most women with chlamydia or M. genitalium don't have cervicitis. At least, the findings on examination. And so, a woman who has persisting vaginal discharge complaints, you rule out other vaginitis causes, you rule out other STIs, it makes sense that, this is likely M. genitalium causing this. And so I don't think you needed to do a pelvic exam at that visit. She didn't have any pelvic or abdominal pain complaints that you could simply have done that. So I think that was reasonable to test her. But here we are now. She's failed the sequential therapy with doxy and azithromycin. She's got persisting vaginal symptoms. How do you evaluate this patient, and how do you manage this patient? And this is basically the point that, she's going to get referred to me for further assistance. Anybody, what would you do next, I guess? Would you test her again? Would you treat her?
So at her initial exam, did she have cervical motion sickness, pelvic organ?
No signs of upper genital tract infection. No cervicitis findings. Simply vaginitis findings diagnosed with bacterial vaginosis at the very initial presentation. Do you test her for M-Gen again? She failed the therapy that you gave her. Do you?
I don't have
And I think that's a very common approach I see many people do, which is just go ahead and empirically treat. Pretty much almost every city now in the U.S. has an MGent test. The question is, where is it and can you get it? A lot of commercial labs have their own. A lot of use Logic and other assays. So they're out there, but can you find it? But treatment-wise, that's the question. What would you treat this patient with? Vaginitis symptoms, remember the flu-like symptoms, right? So the presumption is that she has a cervical infection periodically during the day. Cervical discharge is getting into the vaginal area. But when you see her for that one point in time, when you put the speculum in there, you're not seeing that. Probably if you tested farther out, maybe at 4 weeks, that's probably a safe time point. There's more limited data, but some of these assays that detect nucleic acids, they are going to still be fairly sensitive, within probably a couple of weeks. So you want to push it farther out. So those are good comments. I'll move on to tell you what happened. So the GYN provider saw her back, she had failed this regimen, did not give her any treatment at that point, wanted to do repeat testing to be kind of convinced that maybe these symptoms were due to M. genitalium. Got the same big multiplex panel, and the only pathogen at that point isolated was M. genitalium. Was negative for everything else. And so basically that's when the patient got referred to me. I felt very comfortable that this persistent kind of vaginized complaint was likely due to M. genitalium. That's how I felt about it. And I decided that, I wanted to go ahead and test her again, and we can do the MRN test, so we did it, but I also wanted to go ahead and treat her at this point. And so, but I did not want to give her a quinolone because I was concerned of her reaction. So I gave her minocycline, which is another tetracycline for 2 weeks, which we had some experience with. And basically her vaginal symptoms resolved. I wasn't going to recommend a test of cure. I felt fairly comfortable, but she decided to get one on her own because she was anxious about it. 4 weeks later is when she did it, and it was negative at that one time point. So, the presumption is that now she's cured with this minocycline regimen. And if you're not familiar with minocycline, it's a very old tetracycline class antibiotic. It's one that we and a small number of others had some experience with, and be able to treat patients who have failed doxy, azithro, or moxifloxacin with a 2-week regimen and cure them. But we don't cure all of them. So it's just one salvage therapy option. It's very cheap, which is one of the great things about it too. But the problem with it I've experienced in my use is that it has some other side effects we don't see with doxy, things like numbness, burning pain, dizziness, muscle, joint pains. And so particularly like the dizziness is one that some patients just don't tolerate. But we like to use this one when they fail the other regimens because, again, it's just cheap and easy to find. Yeah. Dr. Musney.
Like evaluating her again for persistent BV and retreating her for BV.
I didn't say this, but she was evaluated for BV again, and that was absent when she came back for follow-up. So, and they did that in the clinic setting with a wet mount. And I guess this assay that they sent also has some of the organisms for BV, I think, as part of this multiplex assay, and that was also negative. So I think her wet mount was negative when she came back, and that's why they decided to add MGen, because they felt she had a persisting vaginal symptoms that might be related to Mycoplasma genitalium. Any other questions before I move to case 2 here?
I actually think that's a really critical point, because that's what I was going to say when you were asking your questions, is that you really can't distinguish between cervical infections and vaginal infections as clearly as we would like for that to happen. And so running these panels, so for example, on the Hologic assay right now, you can run chlamydia, gonorrhea, trichomonas, you can run a vaginitis panel, and you can run Mycoplasma genitalium. And especially if you have somebody with recurrent disease, why aren't we routinely telling people run all of these, because they can be there at the same time? So finding one doesn't rule out the others, and how do you know how best to treat if you don't know the whole picture?
Yeah, good point. All right, case 2. 21-year-old female, 31 weeks pregnant, presents to initial OB visit. This is obviously kind of late to present for initial OB visit. There's some complicated background I'm not going to get into there. But she basically comes in for this initial OB visit with 3 days of kind of new yellow malodorous vaginal discharge. She has a pelvic exam done, which does not show cervicitis changes, but she has thick white vaginal discharge. This is not a patient I saw, but I was a consultant in this case. She had a wet mount done that was unremarkable, other than a small number of white cells. She had this multiplex PCR panel sent. This one tested for gonorrhea, chlamydia, trichomonas, some BV organisms, Candida, and M. genitalium. And the only one of these that returned positive was M. genitalium. This was her first presentation. She was negative for other pathogens. Of course, this assay did not include testing for MRMs. And so the first question I have is, which is building off, I think, some of the comments earlier, should she have been testing for M. genitalium at this visit? It was kind of included in this package deal with this assay, but if you could have maybe chosen the test, would you have done M. genitalium at this first visit? Anybody want to? I see almost everybody's shaking no. But certainly it's not recommended in the guidelines, you would want to evaluate for other pathogens, I think, first. But, you get in this conundrum about trying to treat M. genitalium in a pregnant woman with limited options, and it may not even be a significant pathogen. There's a big debate. So certainly she did not meet CDC guidelines. She had this first presentation of this inflammatory syndrome. The CDC guidelines actually only say cervicitis. They don't say persisting vaginal discharge, just getting to your point. But there's some other studies published where persistent vaginal complaints has been pretty consistent with M. genitalium. So I don't think any of us, it looks like, that agreed to shake her head would have done M. genitalium at this first visit. But she's got it. She's got M. genitalium positive test. She's got symptoms, and nothing else is positive. And, and it's like this yellow, thick white yellow malodorous discharge, and there's no other obvious etiologies identified. So how would you manage this patient? Do you treat her? And if you treat her, what do you treat her with? Anybody want to say anything? Maybe do the would you treat her, shake the head thing. I'm looking around. Would you treat this patient? Did everybody hear that? So there's really not, I'd say, consistent data that M. genitalium causes perinatal-related complications, and that this will lead to a bad outcome for the baby or the mother. And then there's the risk of giving any antibiotic. And there's limited options of which antibiotics that you can give to a pregnant woman. So I was basically pulled in right early on this, they thought, what do you think about this? I'm like, gosh, I really wish this patient was never tested. That's what I think, right? Don't do this again. But, it's just the way that this is going to happen when you have a test out there, right? So we had this long discussion, which is most of what you said, that it's hard to know whether they should either treat this patient or not. Ultimately, the providers wanted to treat this patient. They knew they didn't have the MRM results. And so they decided to give this patient the extended azithromycin regimen of 1 gram day 1, followed by 500 milligrams daily for 3 days. They felt benefit risk-wise, it's probably safe. We'll give it a try. Her symptoms did get better because probably the bacterial load was lower, but they didn't go away. And so then they decided to basically do a test of cure. That was one of you asked me about that, and they did it about 4 weeks later. They asked for it. They got it. It was positive again. Not surprising. The majority of even pregnant women will have an MRM strain probably. So then it was this awkward discussion with the patient. Most of what you just said about what the treatment options, the benefit risk, and then ultimately the patient and provider in a joint decision decided basically don't do any further treatment and just monitor the patient clinically. So that's what was done. And then I'm not sure if it was the discussion that made the patient go into labor, but 4 days later, the patient goes into labor, delivers the baby uneventfully, the baby's fine, and then they basically treat the mother in postpartum unit with moxifloxacin for 7 days. And then for some other reasons, the mother's kind of lost a follow-up, so they never do a test to cure. So I'm not saying this is what you should do, but this is the first time I was put in this situation with a pregnant patient, and I think it's quite challenging, right? Because like you said, MGent treatments in pregnancy. You want to comment or you want to hear?
No, just quick question.
Yeah.
Did you recommend treating her partner? Was this a reinfection or?
Her partner was treated with the same regimen at that time. I don't recall what happened as far as once she was positive again about whether that was an issue. I'm not sure. I mean, normally we would want to treat the patient and partner with the same regimen and obviously counsel them about about that. So, but I'm not sure about that part with the partner. My sense was they thought that she failed treatment, that the issue wasn't re-exposure. So it was, as was already said, basically macrolides are really the only drug with MGen activity and efficacy data that are available in the U.S. that would be considered, I guess, somewhat safe to use in pregnancy. That really you avoid the tetracyclines and quinolones if you can. Even though we had that, that case yesterday with the rickettsia, and that was different. That was a patient that was really, really, really sick. I think you can justify just short dose tetracyclines in that setting, but probably not for this without stronger data that it's going to cause harm to the mother. But there is a drug called pristinamycin. It's available. It's actually made in France, but available in several other countries. This is from an antibiotic class called streptogramins. And some of you, maybe older physicians, might have heard of a drug called Sinercid. We used to use to treat for VRE. It's in that same class of the streptogrammins. But this is one that's a pregnancy category B. You take it orally 4 times a day. It has very good in vitro activity against macrolide sensitive and resistant strains. And there are several published studies with pristinamycin. The latest one showed cure rates about mid-70s percentile. So it is an option, but how do you get that drug into the U.S.? Well, I've done this once for the next case, I'll tell you. And what I had to basically do was I had to get approval from the FDA through this expanded access IND. I had to get the company Sanofi to give me approval and give me the drug for the patient. I had to get local IRB approval, and then I had to get patient consent. That all took about 3 weeks, and it was a lot of work. But for this patient I'll tell you about next, it was really worth it. And so I don't think every pregnant female that has MGENT, you're going to go through all this to try to cure them. But what I would like to see at some point is figure out a way that we can get this drug available in this country without having to do a bunch of large clinical trials to get FDA approval for pregnant women if we go down this path of treating them. All right, the last case, I'm going to make this quick because basically I can't give you all the information. We've been managing this guy for several years. So I'll just jump right to it. Young adult male with congenital agammaglobulinemia. He's got no functional antibody. But he gets IV antibody infusions once a month for his life. And so with those antibody infusions, he can live relatively normal life into adulthood to start having sex, which is what he does. And he gets M. genitalium urethritis. And basically, he's negative for all other STIs. And early on, we tried to treat him for his persisting urethritis with doxycycline, azithromycin, moxifloxacin, minocycline. He failed all those treatments. So that brings my question, what other salvage off-label M. genitalium treatments are there in the U.S. that you can try? Does anybody know? Anybody want to shout out any other ones? There's only 2 that I'm really aware of, and so I'll quickly tell you about the 2. One's a drug called metacycline. This is a very new tetracycline. It just recently got FDA approved for skin infections and community-acquired pneumonia. You take it orally. It's not generic, so it's basically like a few $1,000s if you had to pay out of pocket for 7 days. It's really well tolerated, like Doxy. There's basically no published in vitro or clinical efficacy data. However, because we can grow MGENT strains in our lab, we've actually tested against several sensitive, several strains that are sensitive to other antibiotics or resistant. And basically, in this bottom table here, I'm showing you that top strain, ATCC, is a very sensitive M. genitalium strain. Those 2 bottom strains from UAB are both tetracycline resistant. I'm not aware anybody has actually ever reported a true tetracycline resistant MGENT strain, and these are 2 different patients. Both are agammaglobulinemia patients, so they're immunocompromised. But their tetracycline MIC, one was 16 and one is 8, and that's very high. They've both been exposed to doxycycline more than once. So this makes me worry a little bit about inducing resistance by just using doxycycline all the time. But omadacycline was the best of all the tetracyclines in vitro, including it wasn't affected by the tetracycline resistance, which leads me to believe that it could be a good drug to try for salvage therapy, but that would be off-label. There's just simply no published data at all. And so this is one to keep an eye out for. And then a drug called lefamulin. I don't know if you're familiar with it. Some call it lefamulin, but this is also from a newer drug class called pleuromutilins. And they recently became FDA approved for treating bacterial pneumonia. This is one you can give orally twice a day. It is, again, $2,000, $3,000 if you had to pay out of pocket. Its side effects are very similar to azithromycin, GI side effects, risk for QT prolongation. There is published in vitro data, and it looks like it's really good MICs, or very low MICs for M. genitalium, but there's no published clinical efficacy data. And so we tried both of those antibiotics, and we imported pristinamycin for this patient, and we still not cured him. So I've been following this patient. He's like a petri dish, basically. We've been following him for a few years. Periodically, he gets like epididymitis as his bacterial load gets higher, and we try to knock it down with drugs that won't cure it, but will knock down his load. And so we've got at least 2 patients right now. There's no drug in the world that we can cure. They're adults or sexually active. That's kind of scary to me. There's no other treatments I'm aware of that are going to cure these patients. And we tried like manipulating the intravenous immunoglobulin doses that we give them for higher doses and stuff, and it just doesn't make a difference. And so quickly to summarize, basically treating M. genitalium is tough. Monotherapy may not be a great option. Sequential therapy is what's recommended with Doxy on the first 7 days, and then either a macrolide if it's macrolide sensitive or a quinolone. However, we're seeing patients already start to fail that because of multi-drug resistant strains. And when that happens, I would suggest you try 2 weeks of minocycline as your first salvage regimen. If you fail that, then omadacycline or lefamulin might be 2 off-label salvage regimens. They're very expensive, but I think ultimately we need new genitalium treatments. And I think that's really the point I want to make after these cases. And so for pregnant women, for immunocompromised, et cetera. So thanks everyone for sticking around. We do hopefully have some time for questions. Feel free to have any questions or comments from Bobby or I or Damon. Thank you.